Today's discussion was great on arthritis of the knee. You posed a question that I think we should consider when talking about all of these options, and that is the why question. Could you talk a little bit about what we were discussing?
Yeah, so today we talked about using the clinical practice guidelines that the AAOS came out with. AAOS is the Academy of Orthopedic Surgeons, about how to treat knee arthritis non-operatively. And these guidelines, I think a lot of times we will use guidelines as more of a, this is how I have to practice, without stepping back and seeing the big picture. Which the big picture should be, why did they give the recommendations or the against recommendations, and what benefit will it have to the patients as a whole? And we should step back at every time we have a patient come in with a preconceived notion of, hey, I'm coming in because I want a steroid injection or a gel injection, or I just want a therapy visit, of being able to step back and really ask the question, okay, great, we would be happy to do this. Let's talk about why you want that, and let's talk about why I think that is good or not good in your situation. And as we do that, I think it helps us to better treat the patients with what they need and help answer the real questions that they're not asking, which is really, how are they going to get better, even though they may not fully understand why that thing will help or won't help them.
Mm-hmm. You mentioned too, one of the recommendations is patient education, and at the end you said that patient education is patient empowerment. Mm-hmm. And how does this question of why and that educational component, how have you seen that to be valuable in your practice?
Well, I think for that specific reason is the reason why I decided to actually become a physician. Mm-hmm. I love teaching, and I love that moment when you're teaching them, a student or anyone, a principle, and they just get it. And I know you've seen that, where you just go, oh, wow, that makes a lot more sense why this is happening. So that is what fuels me to be a physician, to be able to see them empowered and really get it, because then it becomes a treatment group rather than I'm the treating physician. It's me and the patient treating their condition as a team. Mm-hmm. And when we do that, I think the patients are happier. They understand their condition, and therefore when we do have to do surgery, or when we get to avoid surgery, they're on the same page. Their satisfaction is better, and so is mine, because I'm doing the right thing for them and they're happy as well.
How often when you're having these conversations with patients is the why question directed towards what are you seeking to accomplish, or what are your goals here? What is that kind of the direction you go with patients usually?
Yeah, I think one of the examples I brought up is when a patient came in with a list of what they will not take from medication standpoint when it's come time for surgery. So obviously they know that surgery causes pain, and she came with a, here's what I don't want to take, so will you still treat me? Mm-hmm. And I think the initial thought for most surgeons is, well, if you want me to operate on you, I have to control your pain. Mm-hmm. So, you have to be able to take this, this, and this, or else I can't help you. Mm-hmm. But the first approach I took was, okay, let's talk about why you don't like these medications and why you use a lot of these holistic medications, which I think are great. But let's talk about what are the reasons, and then let's come to an understanding. So then I can tailor and go, oh, you don't want to take Tylenol because you've had an interaction with a family member who had too much of it. Or, oh, you don't want to take pain medication because of this happened to your family. And then it changes that interaction as to why, and the patients we're able to tailor the specific treatment to them.
Mm-hmm. I really liked that. There were some recommendations made for non-surgical management of arthritis of the knee that have good evidence. What are some of the things that patients can do to manage knee pain and arthritis of the knee without just jumping to an invasive procedure or surgery?
I think one of the big ones that changed in 2021 when they updated it was topical anti-inflammatories, the ability to get something that was prescription-based. And so because of that, in the past, it was more, not frowned upon, but it wasn't as recommended as highly from these group of orthopedic surgeons, is now that it's over the counter, it's a lot more affordable. And with that, they're able to do more studies. And since they were able to do more studies with better affordability, they were able to see more lasting results. So I think that's one that we don't use enough. I think another one is one that I talked about as being a little bit obvious, but is physical exercise. Mm-hmm. A lot of times patients come in and they think, well, I'm not allowed to do this because I have arthritis, when really it's the opposite. You have arthritis, man, get up and move. That's going to be better for your joint. It's going to make it so it's not stiff. It's going to make you stronger. And yes, is it going to progress your arthritis or maybe cause a little bit of inflammation? Yes. but not enough that a replacement, which is probably where they're heading in the future anyways, isn't going to be the answer anyways. So during that time, they can stay active, they can still do what they want to do, and we can support them with some of these non-operative stuff during that time until they are ready for the operation. But I think exercise is another one I think we miss.
I do too. Some people with the spine problems will say, well, I'd like to exercise, but I can't because I have a degenerated disc, or in your case, maybe I'd like to exercise, but I can't because it causes my knee to hurt. Getting into the why questions, what are the goals, and then emphasis on staying active through the process is very valuable. I like the patient education as being a key component, and that was one of the highly valued recommendations. I think it's one of the reasons why, maybe the reason why we do these post-rounds conversations. It's one thing to sit through and listen to 30 minutes, which is available, but this is an opportunity to learn what the high-yield things are for patients, and it's one of the things that we do in an effort to educate. I'd like to go back and look at the topical NSAIDs for spine, because I had never thought about that much in managing arthritic conditions of the spine, because if it works for the knee, it may also work for lower back pain or neck pain as well.
And I think we have a lot of patients that come in with heart issues, kidney problems, stomach problems, where right off the bat they're told, nope.
No NSAIDs.
Yep.
Yeah.
And I think that's a great way to help support those patients, and there's some good efficacy and evidence to show it today.
Well, you've got to run off to the OR, I think. But I appreciate you doing a wonderful rounds discussion and sticking around after with us, and having you here at Summit.